Dr. Leonie Herx is the past chair of the physicians, the palliative care physicians organization in Canada nationally. She's certainly an expert in hospice palliative care, and she's become an incredible expert on the issues related to euthanasia and assisted suicide. Dr. Coelho is here in London, Ontario. She's a family physician. I hope I didn't pronounce her name wrong. But she deals with patients who are vulnerable. Her primary population she deals with in her patient community are patients with disabilities, people who've recently got out of jail, new Canadians, and she's decided on purpose to have a population of patients that she's caring for who are specifically vulnerable. So I'll let the ladies take over.
Thank you, Alex. Leonie and I are two of the co-leads in a group called Physicians Together with Vulnerable Canadians, where we co-authored a statement condemning this bill that we're going to discuss now, raising concerns, and about 1,100 doctors across Canada have signed our statement. Today we're presenting about Bill C-7 and the implications of expansion. Leonie, I'll just let you know when slide change. But to briefly first review history, then to explore C-7 and its expansion, and to discuss the impacts of this bill on the practice of medicine. Go ahead. Here in Canada, we call euthanasia and assisted suicide together medical assistance in dying. I won't go through the definitions as our previous speaker did so very well. And just to clarify, in Canada as internationally, people are choosing this for existential suffering. The public often perceives this as choosing death because someone's in intolerable pain or very short of breath and in agony, but actually it's often fear that drives the request for death. Next slide. Also, what we'd like to discuss is that MAID criteria eligibility is being driven by court cases and legislation, not by medical evidence. And that's very unusual. Medical care is based on averages and on evidence. I'd like to share an example. It impacted the States too, but in the 1990s, there was a public perception that bone marrow transplant with high-dose chemotherapy was going to be a real game changer for women who had breast cancer. That they'd do better, they'd live longer, they'd suffer less, and this really took hold of the media, of legislatures. You had policymakers mandating that this was given as first treatment. You had insurance companies that were forced in the States to pay for this. And eventually it was found out through medical evidence, through 4 studies, that this is actually a very dangerous practice. And so many women were hurt when legislation drove and demanded what doctors should do. Next slide. Thank you. In Canada, before 2015, it was impossible to consent to being killed. But with the Carter case in 2015 that struck down the criminal prohibition on homicide and assisting suicide for the purposes of MAID. In 2016, we had our federal bill that kind of rolled out how it would be done, C-14, and now in 2021, we are considering a bill that was introduced in February of 2020 on MAID expansion. Currently, it passed the House and it's before the Senate. And in future, our Justice Minister has already said very shortly we'll be studying and possibly also expanding to mature minors for mental health solely and advanced directives. Next slide. In terms of the initial discourse that started in Quebec in terms of decriminalizing euthanasia, would be an exceptional situation, would be rare. Gaëtan Barré suggested less than 100 requests for the first year. You can change slides. But that is not shown to be the case. Canadian MAID stats are appalling. We are at 21,000 deaths, I think if quoting Alex, to date. 2% of all deaths are MAID deaths with regional variation, and we'll get to that later about what that means. And cases are steadily rising each year. So Dr. Herx and myself live in Ontario, And right now we're at a rate of 200 in the province a month. I'm going to turn over slides to Leonie now.
Thanks. I think just to finish a little bit of the background of C14, because it does lend itself to a better understanding the changes in C7. So I hope you don't mind just if you're familiar with it, but we'll just walk through it anyway. So when C14 was enacted, it made part of the Canada Health Act, and it was had to be publicly funded and available to all Canadians as an essential medical service. But very importantly to note that there's no similar right to supports needed to help with living, such as home care or disability supports, as well as palliative care, which is my specialty. And we know that palliative care is severely under-resourced in Canada, with less than 30% of Canadians having access to it. Only about 15% having access to specialist palliative care for complex cases. In Ontario, we have data fairly recently that showed very few people, less than 15%, were able to get palliative home care services in their last year of life. The eligibility criteria for MAID under C14 was that you had to be eligible for publicly funded healthcare, at least 18 years of age and capable of making your own healthcare decisions, have a grievous and irremediable medical condition, which does include illnesses, diseases, or disabilities. Your death be reasonably foreseeable, and we're going to talk about some of these terms in bold in a few minutes. Your request must be voluntary, and you must have information about other options for care. So the Supreme Court of Canada, in their Carter ruling, which led to the C14 legislation, said that a carefully designed and monitored system of safeguards would limit the risk of wrongful deaths of vulnerable persons. And in the legislation, they put in the following safeguards. So there would need to be 2 independent assessors that determine that you're eligible for MAID, that there'd be 2 independent witnesses that sign that you're not choosing MAID out of pressure or coercion, that you would have capacity both at the time of the request to receive MAID and at the time of the administration of the lethal injection, that there would be a 10-day reflection period between those 2 pieces, so request and delivery of the injection, because many people do change their minds, so that was built in to allow some time for people to reconsider. That you would meet all the eligibility criteria, of course, and that you would provide informed consent and be aware of your other options for care. The Supreme Court proposed that a rigorous system of monitoring review would be put in place by the government to ensure that these safeguards were being followed. So first I want to just speak to the system of monitoring review, and then I'm just going to briefly go through each of these safeguards and talk a little bit more about them. So actually there was kind of a patchwork of monitoring that was happening up until November 2018 with no standardized system across the provinces. And in Canada, healthcare is provincially mandated. So it was left to each of the provinces to determine how they were going to collect data and what they would collect. And then in November 2018, Health Canada established a federal monitoring program that collects basic demographic information, such as age, postal code, but not collecting really important factors that we know influence vulnerability, such as race, socioeconomic status, language abilities. It's entered into a system differently in each province. So some systems are in place where you go through the coroner's office and it gets sent to Health Canada that way, such as in Ontario, or some provinces say the MAID providers enter it directly into the Health Canada system. But the important piece is that this is entered by the MAID providers themselves and is left to their interpretation of the reasons people are choosing MAID and the information on the patients. And it is only reviewed in retrospect. So there's no real-time monitoring. If a red flag is raised, for example, this patient didn't have access to palliative care or disability supports, that's simply a checkbox that would be seen at some point later down the road, but there's actually no system of stop mechanisms to halt the procedure if there's something that's not quite right. For example, if coercion is concerned about it, it's left to the MAID assessors and providers to determine whether it's okay to proceed. In terms of the safeguards, a number of concerns have been raised and documented in the literature. So the 10-day reflection period is often not being followed. A more recent report from Ontario shows that about 26% of cases have the 10-day waiting period waived. And a study from Quebec, so Quebec actually is the only province who issues annual reports and has an end-of-life care commission that collects the data that they put together at the provincial level and shares that. The Quebec End-of-Life Care Commission has also found similar evidence, and one study by Seller et al. Found that of the people who had the 10-day waiting period waived, which was 60% of cases in that study, 48% of them didn't meet the criminal code criteria for waiving the 10 days. So it is allowed to be waived if you have risk of imminent loss of capacity, or you're going to imminently die within those 10 days. So almost half of those that had the 10 days waived in their study did not meet either of those two criteria. And almost a quarter of those had no documented reasons for waiving the 10 days. With respect to capacity, as physicians, we know that assessing a capacity for someone to make healthcare decisions is not often straightforward and can require quite advanced skills. There's no mandatory training and no requirement for psychiatric consultation to take place in complex cases of capacity. And so that's been raised as a concern. And we have documented reports of patients who other physicians on the team felt that the person did not have capacity, even wrote in the medical record, the person didn't have capacity and asked for a psychiatric consult, and none of those interventions were done, and the patients have received MAID regardless. There's been documentation of assessors not being independent. In fact, the End-of-Life Care Commission in Quebec also raised that in their reports. Another concern about the independent, not a lack of independence in the nature of the assessors, is that the second assessor can see the first assessor's report. And so oftentimes it's a small group of physicians who are part of the euthanasia provider community, as it is in many other jurisdictions. And so they're often colleagues who work very closely together. There's been concern raised around the eligibility criteria, both at the level of the regulatory colleges for physicians as well as by the courts. So in Ontario, the College of Physicians and Surgeons has said that the definition of grievous and irremediable is not consistent with clinical terminology and therefore not meaningful for physicians and would be objectively difficult to determine what that means. The reasonably foreseeable death criterion has been challenged in the courts and overturned by a superior court in Ontario as well for being ambiguous. And that Justice Perel, in his ruling, where a woman with osteoarthritis who is 77 years of age wanted to have MAID because of her suffering from her arthritis, during that ruling, he said that actually prognosis is not relevant to what is reasonably foreseeable death, and he approved her case to go ahead and get MAID, which is therefore set precedents for other cases that have come since. And then lastly, around informed consent, and I'm not going to speak to the witnesses because that's a change that we'll hear about in C-7. Informed consent, some people have questioned whether if all you're provided with is information on what your options are, but don't actually have those options accessible in any meaningful way. For example, you live in an area where there's no access to palliative care, is that truly informed consent? So Dr. Jared Kodelik, who is a bioethicist who works in Thunder Bay in Ontario, recently published a paper in the Canadian Journal of Bioethics, and he studied the provincial monitoring systems and all the data that we have collected to date since legalization of euthanasia in Canada. And he has determined in his paper that there's insufficient evidence that the MAID program is operating as mandated. And I'd like to give you a quote from his paper that just came out. The Canadian Medical Assistance in Dying program, based on an ambitious piece of legislation and detailed regulations, has failed to provide Canadians with sufficiently publicly accessible evidence to show that it is operating as mandated by the requirements of law, regulations, and expectations of all stakeholders. In his study, he showed that by the end of December 2019, over 13,000 Canadians had died with medical assistance in dying, and of those, 10,000 of them, there is no publicly accessible evidence that they met the eligibility criteria or that the safeguards were prescribed by the law were being respected. this concern around lack of adherence to safeguards has also been documented and outlined in a paper that I published with some of my palliative medicine colleagues in the World Medical Journal in April 2020. So if you're interested in reading more details and references in the evidence, that's summarized there. And another area of concern is that because of this, the C-14 and the legislation for MAID is actually a criminal code criteria exemption, yet healthcare is provincially regulated. It's not really clear who is actually going to oversee the system. So the federal government under Health Canada is basically just collecting societal level demographic information. But the regulation of physicians, so if somebody were to be concerned that someone hadn't followed the regulations or safeguards weren't being followed, who would they complain to? Would it be the police because it's a criminal code issue, or would it be the regulatory college who oversees physicians? And so it's quite unclear who to go to when there are cases of concern. And numerous compliance concerns have been documented by the Quebec End of Life Care Commission. Each year in their reports, they've documented concerns. The Chief Coroner of Ontario and the BC Coroner's Service, whose last report was published in 2017, but at that time they documented substantial issues with concerns as well in the documentations of 40% of cases at that time did not have complete paperwork. And this is an example of a report from the Office of the Chief Coroner in Ontario. And I'll just read out the paragraph that's pointed to in the arrows. Some case reviews have demonstrated compliance concerns with both the criminal code and regulatory body policy, some of which have recurred over time. However, to date in Canada, no doctors have been charged. Thanks, Ramona. Ramona, can you speak?
Now I can speak.
Okay,
sorry.
you were muted.
I had muted myself. I'm so sorry. I was trying not to make noise for your talk. Sorry. Okay, so moving on, Dr. Herx has done a great job of outlaying the history of C-14, and I'm going to move forward now. Again, talking about a court case, which is what is driving changes to medical practice. So the Trishan Gladue judgment, which was handed out in September 2019, led to this bill that was before us. Trishan was a quadriplegic who had cerebral palsy. Gladue has post-polio syndrome, and both did not qualify for MAID under C-14. And the lower Quebec court, Justice Baudouin, decided that the requirement to have a naturally foreseeable death was not fair, and so she struck it down. The government did not appeal the decision, and then the court then gave the government 6 months to amend its MAID law, and through various extensions, we're now at a new deadline coming up next month of February 26, 2021. Sorry, Leonie. A Globe and Mail article outlined the fate of Trishan. He decided to choose an early death through MAID, saying that COVID-19 had forced him to do so as he was isolated in a long-term care center. Quote, "The coronavirus has literally stolen my time with those I love." And I think it's important to note that the COVID-19 pandemic, especially in Canada, has increased wealth disparity, furthered loneliness, and social isolation. Next slide. As I said, when the Trishan case was heard in Quebec, the lower court judge struck down the need to be dying, and the government did not appeal this decision. And it's important to note that many disability rights groups, many influential doctors raised the alarm about this court finding, and nevertheless, they were all ignored. Next slide. In terms of a summary of this proposed bill, there are 2 tracks, and each track has a different timeline and safeguards, which I'll go through with you. The first track for those who are dying, and the second track for those who are not dying. So chronic illness and disability. Next slide. You saw that Leonie had done a great job of constructing this pictorial of the safeguards, and you can see that the government, and given like Dr. Kotelek and Dr. Herx's demonstrating the abuses and the lack of proper maintenance and protection of these vital safeguards, that actually in this bill, the government is dismantling them all for track 1. So you don't need to have 2 independent witnesses anymore. You can have 1 witness, and it can be a paid caregiver. You don't need capacity on the day of receiving your MAID injection. So you've lost capacity. The doctor can go through and give you that lethal injection regardless. The 10-day reflection period will be gone. So it won't be a matter of just waiving it now. It will be a matter of that will be the norm. And so people can request MAID and receive it on the same day. And the eligibility criteria in terms of protecting everybody else, it's no longer just for the dying. In terms of informed consent, we're going to talk about studies and just a little bit about why informed consent is questionable in general. And 2 independent assessors has not really worked out either. We're not going to go through that literature, but really a lot of the second assessments are done through someone who's been able to see the first report or through a phone call, which is clearly not an independent assessment. Next slide. So let's read this slide. So only 1 witness now and can be a paid healthcare worker, but you need 2 witnesses to sign your will. No reflection period, so you can die the same day as the request is made, but we have evidence that shows that people change their minds. A loss of capacity to consent, and you can still go through with MAID. The laws of sexual consent in our country are stricter. So creating a will, oh sorry, Leonie. So creating a will and in terms of consenting to sex are more rigorous safeguards than it will be for death. And I'd like to also share a quote of Dr. Jean Memorio. She's one of the founding members of CAMAP. So CAMAP is our group that actually is for MAID. It's the Canadian Association of MAID Assessors and Providers, and the medical advisor and she's a medical advisor of Dying with Dignity. So she's for MAID. But hear what she says on only 1 witness. Right now, neither of the 2 people who witness your request for MAID can benefit in any way from your death or be involved in your direct care. But with just 1 witness needed to sign, there's a greater chance of abuse and mistakes. Her conclusion, let's keep 2 witnesses. On waiving the 10-day reflection period, the obvious danger here is that your last act will be impulsive. Under C-7, I'll be canvassing more specialists, because with the loosening of the criteria for MAID comes the risk of making a terrible mistake. And just paraphrasing, her conclusion of this write-up is that Bill C-7 should not go forward as it is, that it's too dangerous. Next slide. Thank you. On the left, you'll see that this is for the people who are not dying, so they have to have a serious incurable illness, be in a state of decline. It can be physical or psychological suffering. You need 2 MAID assessors, and unlike the 10-day waiting period, which will be waived, they're introducing a 90-day period from first assessment. So if you're not dying, you could potentially access a lethal injection in 90 days. An expert in your disease process has to be involved, but it's not clear in what form. And you have to be informed and offered treatment options. And I'd like to say that that doesn't mean that there's a requirement to actually have those treatment options available. In the other jurisdictions where this is legal for non-terminal illness, a doctor has to sign off that other care has been exhausted first. And in Canada, 70% of the dying do not have palliative care. The waiting times to see a psychiatrist, physiatrist, rheumatologist, or pain clinics can be 4 to 8 times longer than the 90 days to access death. Next slide. So basically, when we're talking about track 2, who are we talking about? So chronic disease, disability, a mood disorder, a mental health disorder, if they happen to have one of the first 2 criteria, would qualify. And basically, through the court expansion of this kind of definition, basically any chronic disease, even osteoarthritis before the courts, has been clarified as could be a potential reason to choose medical assistance in dying. Next slide, thank you. In terms of suicidality, we know that suicidality in chronic illness and disability, consistently across many different studies, is overwhelmingly transient, but can take on average 2 years to go away. So, and suicidality peaks at 90 days. So the government giving people a 90-day window is extremely dangerous in light of that information. Next slide. This study was presented last month, last month in December for PMR, so Physical Medical Rehabilitation Canada. The doctors presented this study where they started the study before Bill C-7 was on the table, and they interviewed 23 people who had a spinal cord injury. And the majority of the people with a spinal cord injury were in fact suicidal when they realized that they were paralyzed. And despite that, none of them today would want to pursue MAID and are very happy with their lives right now. And all participants stated that they would not have been able to make an informed decision about MAID early post spinal cord injury. Dr. Ethan, so the middle author there, shared that many doctors who work in the emergency and intensive care settings can have a profound impact on her patients after injury when they are most vulnerable. In her experience, these doctors may have inaccurately presented future outcomes to her patients. Dr. Ethan shared that most people are suicidal after spinal cord injury, but after rehabilitation and integration back into the community, the majority have the same quality of life ratings and in fact higher than the non-disabled population. She says being offered death in the early period when they are vulnerable is a failure to understand medical evidence around injury and recovery. Next slide. On the bottom here we have David Shannon, and these are two amazing people who might not be here today if MAID was legal when they had their injury. So David is a Canadian disability human rights lawyer, and he had a devastating injury, a rugby injury in university where he was left quadriplegic. He went on to get his Master's of Law from the London School of Economics. He's continued in many different roles of leadership. He's made headlines for going across Canada in his wheelchair and planting a wheelchair accessible stake at the North Pole. He's won the Order of Ontario, Order of Canada, and he's just altogether lovely. But he says that he was extremely, extremely vulnerable after his injury. Christine Cowley had an injury 33 years ago. She's gone on to get her doctorate, professor, Paralympian. She's traveled extensively. She's married. She has 3 children, and she's also lovely. But she says that, you know, no one would have perceived that she wasn't in a good headspace. Like, Chris is a fighter. But if someone had offered her MAID in her early years, she might not be here today because it took her years to feel great again. Next slide. I'd like to go further in terms of medical literature, challenge people's assumptions about the quality of life in persons with disabilities. So people have mentioned to me that the reason spinal cord injury patients do so well and have a high quality of life is because they're young when they have their injury, and so they often have time to rehabilitate and return to work. And Dr. Ethan's pointed out the bias of acute care workers who have no proximity to disability in terms of underestimating the function and quality of life of these patients. But I think that that can still fail to shake up our deep ableist ideas, the idea that able bodies are happier and more valuable than non-able bodies. The stroke community who don't have the same ability to return to work or youth have the same benefit, the same rating of quality of life to age-matched healthy individuals. And then if looking at, I think the most, what we would consider one of the most devastating stroke syndromes is locked-in syndrome. So you can't move your body, you can't talk. You might be able to blink and learn to communicate that way. You're cognitively intact. And like stroke, there have been studies that have looked at the quality of life of survivors of locked-in syndrome. The data collected from the patients themselves questions our assumptions made by doctors, healthcare workers, and politicians that this state must be life intolerable. Surprisingly, quality of life in locked-in syndrome is often the same as age-matched healthy individuals. And now I'm quoting Russo et al., the one that I've kind of blown up slightly larger. He concludes, in opposition to a widespread opinion, locked-in syndrome persons report a satisfactory quality of life level that stays stable over time, suggesting that life with locked-in syndrome is worth living. Next slide. So as I said, Ethan's study points out the patients themselves who have lived that experience said that they would not have had the capacity to understand their future, and that for them, choosing MAID, even though they would have, wouldn't have been a free, informed decision. So even though they had peer mentors who talked them through what their future would be like, they had doctors ad nauseum tell them life was going to be great. They didn't believe it until they lived it. And that's why they said that they would not have had informed capacity. And so let's look at this slide. Who in Canada is going to get suicide prevention versus suicide completion? What is easier to access, as this diagram, this cartoon clearly shows? What medical options can you afford if you live in Canada? Who's going to advocate for you? And how does the doctor in front of you value your life? A recent study in BMJ Supportive and Palliative Care says that unexplained 7-fold variation in euthanasia rates across the Netherlands. Findings may relate to underuse, overuse, or even misuse. This study highlights that this is not like a free choice in a utopian society, right? That there are clearly variables that affect who gets MAID and who doesn't. Factors in the study such as church, income, volunteer availability, which suggests a kind of social cohesion, all show that medical assistance in dying is often affected by the social determinants of health that affect all of us. And if we turn to the Netherlands perspective study that was also just done, it showed that when people could choose euthanasia for disability, they'd be making a very complicated choice, that loneliness, poverty, a lack of disability supports, all these things would be playing into their decision. So what does a free and informed choice really mean? And lastly, before I turn it over to Leonie, who's going to finish the slide, I'd like to talk about the physician's perception of the patient's value, which is kind of hidden in all of this, but I think a very important factor. One of my lovely, lovely patients, young lady in her 20s, had an idiopathic cardiomyopathy. So she had heart failure. And as her disease progressed, she became short of breath, she became suicidal, and her family didn't live here. And so I sent her to the hospital for admission for her protection. And that's what she wanted anyways. And I didn't have to do it against her will. She was collaborating, she went there, she was admitted. The next psychiatrist who comes on duty writes to me and says in his notes, that her suicidal desires were valid and suggests that she be allowed to die. So my young patient, who's now terrified because she understands that they're not going to protect her, but she's feeling this kind of, these feelings, comes home, her family comes from out of town. We create a protection and monitoring program for her because the hospital wouldn't protect her. And this patient has gone on, by the way, not that it matters, but she went on to have a heart transplant and she's totally well. And she wouldn't have had that option if medical assistance in dying had been aggressively offered to her and if she had taken it in a moment of vulnerability. Go ahead, Leonie.
Thank you. So Ramona's talked a lot about track 2, which is for people who don't have a reasonably foreseeable death. But this idea of suicide prevention also applies to those people in track 1 that I often see in palliative care. So my colleagues and I have experiences where patients have come into a clinic setting with advanced cancer, hitting all the risk factors for being at risk of active suicide completion with, access to weapons, a plan, a date, all those things that we know as doctors to screen for. And when we've consulted psychiatry to assess those patients, unfortunately, in multiple cases, the psychiatrists have suggested they go for MAID instead. So it's becoming very difficult, even currently in Canada before C-7 is legalized, to know how to do our best to prevent suicide prevention versus suicide completion through MAID is becoming a very challenging area, and it's very controversial, I think, even within the psychiatry community. So I want to spend a little bit of time talking about the impacts now around all of these changes in the Canadian legislation and the medical landscape in the context of legalized euthanasia. Some of it is what we're experiencing now, but then imagine when the gates are open and anyone with a chronic illness, disease, or disability who feels they have suffering can now get MAID, which potentially will be a number of months away. So what we've lived in Canada as doctors is this incremental desensitization of MAID as just a tool in the end-of-life care basket. And that's actually a quote from someone who was profiled as a Canadian pioneer doctor by our Canadian Medical Association. So MAID is really just being promoted as a good way to end suffering. Now we often see that if someone expresses a desire to die or talks about wanting to die, it's interpreted automatically as a MAID request, and many times the MAID team is called before palliative care has even seen them. And that's currently in the context of, reasonably foreseeable death. Imagine again what will happen once C-7 goes through. And, in palliative care, we know that expressions of desire to die, and the evidence is very clear, are often people coming to terms with a new reality when they have a devastating diagnosis. It's an expression of anger or grief, suffering that often reverses itself with adequate supports. And so it's very, troubling that sometimes now it's just a kind of a knee-jerk reaction that the MAID team is involved when someone's expressing anger or grief. In the medical curriculum, once MAID was legalized, the deans all spoke up across the undergraduate programs and said they would make sure this was in their curriculum. Indeed, it's essential healthcare service, and it's supposed to be legally available, and so that has been implemented across medical school curriculums. But sadly, palliative care is not well taught or readily available in all the medical schools. So, in the context of 2% of Canadians currently choosing medical assistance in dying, and 98% of people who die not wanting that, yet we're teaching everyone about MAID, but not about how to address suffering in other ways. It's being promoted, MAID, as a source of organ donation. And this is just a quote for an article clipping from the Ottawa Citizen, talking about how this is going to be a boon to the organ donation in Ontario. So far, we've had 49, according to the latest MAID reports, people in Ontario who've donated their organs through MAID. In 2019, there's a Canadian guideline published in the Canadian Medical Association Journal, looking at deceased organ and tissue donation after MAID and outlining the guidelines around that. And then there was a response written by an anesthesiologist at the University Health Network of Toronto about this guideline that I just wanted to share with you. Dr. Claire Middleton suggests that the widespread availability of relevant information about organ donation and the shortage of suitable organs makes it unlikely that the request for MAID and the decision to donate can be such a linear process. Sometimes people change their minds about MAID right up until the end. I am concerned that once an initial decision to donate has been made, subsequent discussions and the whole process of donor testing may unduly influence patients to follow through with MAID to avoid disappointing expectations raised by their earlier decision to donate. So in terms of risks for coercion, people are often choosing MAID because of existential suffering and feeling their life is a burden. And I wonder about the ethical appropriateness of offering organ donation through MAID when people are at their most vulnerable. And I think that hasn't really been studied, but it is definitely being promoted. And I think, as Ramona as well articulated, there's definitely just been a seismic shift in the role of us as physicians from suicide prevention to facilitating suicide, from offering MAID as a way to address suffering so readily. We see also that vulnerable patients are choosing MAID or asking for MAID due to inadequate care, including the lack of access to care and the cost of care. And these are 3 examples from Canadian media that show that. So the first picture on the left is Archie Rowland, who is a landscape architect in Montreal who vowed to end his life rather than continue to suffer in a long-term care facility. The report outlines, the situation he lived in that was intolerable for him there in the nursing home without good care. Like an average temperature of 30 degrees, for example, like it was so hot he couldn't breathe properly, and he said they were treating him inhumanely. He did end up fleeing the facility, but 3 days later did choose MAID and had his life ended. The second picture in the middle is Raymond Boubonnet, probably mispronounced that, who chose to die rather than live in a long-term care facility as well. And then the third one is Arlene Rainsborough, who said that it wasn't depression that makes me want to die. It's the fear of living with inhumane, overcrowded conditions, loneliness, and the lack of hope. And that was referring to her life in a nursing home. In this case, I don't think she did get MAID, but we don't actually know. But I think it's just another example that we have people asking for MAID who don't have access to good care to avoid suffering in that type of psychological way. And we have recent examples where through COVID, there was a woman in her 90s who had no illnesses but was afraid to suffer through going through another period of lockdown in her long-term care center where she would be socially isolated in her room. She had gone through a 2-week period in the spring where she basically had to stay in her room by herself and had no other human contact. And rather than go through the prospect of that again this winter, she chose to have MAID and received it. So as Dr. Coelho said, these types of disparities have been amplified by the COVID-19 pandemic, but are becoming a reason that people are requesting MAID. I think earlier, Dr. Toffler talked about the cost savings in euthanasia. And in Canada, the last year of life accounts for about 10 to 20% of healthcare spending. An early study after MAID was legalized showed an annual reduction in healthcare spending with C-14 of between $35 to $140 million. That was based on a 1% population MAID rate, and we're already now at well over 2%. And then the Parliamentary Budget Office for the Parliament of Canada put out a report in October 2020 to looking at the cost of C-7, and they estimated an additional cost savings of about $149 million based on an additional 1,200 MAID deaths per year under C-7. And I put the question marks there because we already see an annual increase of about that proportion under the current legislation. And so I'm not certain how they ended up getting the 1,200 figures when now we're expanding MAID beyond this end-of-life criterion, and the numbers could potentially go much higher. And they're only taking into account cost savings in the last year of life, where we know many of these people, even currently and then in future, could have many years left to live. We see that vulnerable patients are being suggested to consider MAID because of the cost of their care, or because, as Dr. Coelho mentioned earlier, there's a perception that their lives are not as valuable as others. So on the left, you can see an example of a patient, Roger Foley from London, Ontario, who has cerebellar ataxia and a progressive disability requiring 24-hour care. And he was living in the hospital because there wasn't the means to provide the care that he needed in the home setting. And hospital administrators suggested to him that he should get MAID because of the cost of his care. And he recorded them, and that recording has been shared in the media. And on the right side is Candice Lewis and her mom, who Candice Lewis had a developmental disability and was admitted to the hospital for an acute medical condition. And while she was in the hospital, it was suggested to both her and her mother that she should get MAID. And the doctor told her mother that she was being selfish for not wanting her daughter to get MAID. And they both felt so unsafe in the hospital that they actually took Candice home and didn't feel they could stay in the hospital any longer. So these are just examples that we know, readily reported in the literature, but we all have personal examples of stories we've seen or heard of people who it's been suggested to them that they should get MAID. One of the things that we're struggling with as doctors, and that's becoming more of a concern to us through C-7 legislation, is that there's been this proposed duty to inform put out by the Canadian Association of MAID Assessors and Providers, CAMAP, who Dr. Coelho referred to earlier. So now back in 2019, they put out this guidance document that says physicians should have a professional obligation to inform all patients with a serious illness about MAID as if it were one of the therapeutic treatment options being offered. So at the time of diagnosis of a serious illness, it should be presented along with all other options for care. But that was just, the CAMAP association recommending it, and nothing has moved forward with that. But now during the parliamentary debates and the testimonies at the Justice Committee for the Canadian Parliament and the Senate, the Federation of Medical Regulatory Authorities of Canada, who kind of oversees all of the provincial physician regulatory colleges, has actually openly stated to those committees and in their written statements that they believe doctors should be bringing up MAID just like any other option to all eligible patients. And under the C-7 legislation, the way it's written, there's no protection currently to prevent doctors from bringing up MAID to patients as a form of coercion, as in the Victoria, Australia legislation, for example, where it says right in the legislation that no healthcare professional must bring up MAID. It must be a patient-initiated request to discuss it, and no healthcare professional should suggest MAID, or in Victoria they call it VAD. We don't have that built into the C-7 legislation currently, and that's definitely something we're advocating for as one of the amendments, but that would be very necessary to prevent patients from being coerced by doctors who are now potentially going to be obligated to suggest it. One of the other concerns of physicians around C-7 is our ongoing rights to be able to practice medicine according to our conscience and what we think is in the best interest of the patient. So currently there's no system in place through C-14, and there are no additional systems being put in place through C-7 legislative protections to prevent forced participation in MAID by indirect and direct manners. So in 2 provinces in Ontario, including Ontario and Nova Scotia, doctors are required to provide an effective referral, which is an endorsement of MAID, and recommending that to another physician if you're not able to provide it yourself. And so that indirect form of facilitation of MAID is currently being required, and now is going to impact a much bigger array of physicians when C-7 goes through, and in a context, as Dr. Coelho said, where patients actually have not even had the standard of good medical care if there's no requirement for MAID to be a last resort. So in Bill C-7, a patient needs to be informed of their options, but not necessarily have tried them. And I know Dr. Coelho spoke to this earlier, but there's only 2 jurisdictions in the world who allow euthanasia outside the end-of-life context, Belgium and the Netherlands, and both of them require MAID to be a last resort. So we could possibly be in a situation where someone has rheumatoid arthritis or fibromyalgia and not have had any standard treatments that a doctor would consider able to address their suffering, and be faced with a patient who's asking for MAID when we know there are things that can help them. Regardless of whether you think MAID is right or wrong, there could be many doctors who would have a patient before them who know that there's still good therapies available to help their suffering, but then they might be required to facilitate that patient getting MAID. There's increasing pressure for institutions to provide MAID. So in Quebec, all institutions were expected to participate. I know there are still a couple of hospices that are faith-based that haven't provided MAID, and they haven't had their funding pulled, but overall it was required that and pressure put by the government to say that if you don't provide it, you will lose public funding, and the strong lobbies have continued to push for that across the rest of Canada. And the Delta Hospice in British Columbia is the most recent example of that, where they have been in a battle for the past year with the Fraser Health Authority over not providing MAID in their hospice, when MAID goes against the philosophy of hospice and palliative care and their their board's constitution for the Delta Hospice. But Fraser Health said a year ago that if they didn't provide MAID, they would lose their funding, and now they're being forced to close next month in February. So what's next? Earlier we heard about a slippery slope. I like to call it actually a logical progression because you can predict where this is going to go, as we've seen in other countries. Once this becomes normalized and just part of in particular part of medical practice, things progress fairly quickly, as we've seen in Canada. So these are the types of things that we're seeing in the medical literature now in Canada and internationally that I suspect we will be having more conversations about in Canada. So organ donation euthanasia, which is where organs are actually harvested while the person is sedated, so that they're not given the drugs that actually end life, so that the organs are more viable. There's actually been some papers that have come out of a Western University in London, Ontario, looking at how that could be done. And a year ago, there was a specific session at the Canadian Critical Care Conference looking at this particular issue. Given that in C-7, you don't have to have capacity at the time that MAID is delivered. I wonder about this new concept that came out of the Netherlands called coffee euthanasia. And what that is that for patients that don't have capacity at the time of euthanasia but have an advance directive, and C-7 allows for a limited advance directive, so you don't have to have capacity, as I said, that might be at risk of being combative and need to be held down, which is the case that this came out of in the Netherlands, that a patient who had an advance directive, the doctor decided it was time for this person to have euthanasia, and the patient had to be held down because they were trying to fight the team off. After that, doctor was accused of not following the rules and then cleared. And it was through that court case that this concept of coffee euthanasia was developed by the system in the Netherlands, so that a sedative medication could be given in the patient's coffee or drink, so that could sedate them prior to euthanasia being administered. And as Dr. Coelho mentioned earlier, as soon as C-7 is passed, our Attorney General and the federal government has indicated that the Committee to Study Advanced Directives, Mature Minors, and Mental Health as a Sole Diagnosis for MAID will be struck, and that those will be, they expect those to be approved. And that's the Attorney General's, definitely the direction that he's taking. This is just an example of us preparing for the day when mature minors will be receiving MAID. And the Toronto Sick Kids, which is Canada's largest hospital for pediatrics, last year published their guidelines for euthanasia for youth 18 years and over. So sometimes kids with genetic or metabolic conditions continue to, even though they're 18, continue to be seen at the Children's Hospital because of their unique conditions and skill sets they need. And so the Children's Hospital needed to develop a policy to how MAID would be provided for those technically adults, but who continue to be seen at the Children's Hospital. And in that paper, interestingly, they stated that the policy was developed with an eye to a future when MAID may well become accessible to capable minors. And there's, in their policy, and you can read it, the references down here, they talk about that they would encourage family members to be involved and for the young adults or youth to share that with their family members. But if the young adult or youth does not want their family members to know, that's not a requirement, it's just a suggestion. So it's possible that someone could be 18 or 19, have, you know, a metabolic condition that they're continuing to be seen for, and that their family members would only find out after they're dead that they've got MAID if they didn't want their family to know. So that's kind of the coverage that we were hoping to do, and we would be happy to take some questions.
I am a registered nurse. I work on oncology. What do you feel is the best approach to change the hearts of people who want MAID? From my perspective, I was a nurse educator for 3 years and decided to go back into clinical practice. And I feel the best approach is to give that exceptional care to show how people are valued. And so when people are valued and feel loved and feel the dignity that is inherently theirs, they would choose otherwise. I was just wondering what your thoughts were.
I think that, you know, our cash-strapped, time-strapped medical system has led to a lot of people feeling they want to die from neglect. And so I do think that you're quite right that exceptional care for all is really what needs to be happening here to turn this thing into something unthinkable. I'll just say before Leonie takes over, because she really is on the ward and so can speak more to your experience. But as a family doctor, I'm in a different position because I journey with my patients for years and they know me well. And I have a good relationship for the most part with the majority of them. So I can just beg. My approach is begging to give me time, begging to try to find solutions, which I guess is the same thing. Go ahead, Leonie.
Oh, no, I totally agree with you. And I think from a legislative perspective, I would say that, you know, C-7 needs to be amended to ensure that people have care provided first. That is, we know people change their minds when they have someone come alongside and help them see hope and that they matter. And that's the way to restore a person's dignity. And we have lots of good tools to do that in palliative care and in compassionate, holistic, person-centered care in family medicine, oncology, and just in medicine in general. I agree with you that it should be care provided first. And actually, my colleague, Dr. Romaine Gallagher, wrote a very interesting article in Policy Options that talks about made as medical error, that for patients who did not have access to palliative care or supports for living throughout their illness, they had been abandoned by the medical system when they could have had care provided that would have, you know, promoted healing and health and restored hope. And so that's a really interesting perspective to think about, that it's actually a medical error that we've gotten to a point where someone feels they're better off dead. So
we're going to thank the two ladies right now for their amazing presentation. They did a grand rounds just, what was it, Monday? Was it the grand rounds, or was it, yeah, I think it was just recently, and it was amazing. The two ladies do an amazing job in research and presentation on the issue. It's actually shocking after listening to Ramona and Leonie that members of Parliament have actually voted the way they have.